So then we start looking at what are the risk factors for muscle injury. So why do muscle injuries occur? Yeah, so we've got anterior posterior deficits maybe of these concentric chains. We've got asymmetry that could be unilateral or bilateral. We've got flexibility, previous injury, which is actually suggested to be the highest, and also strength measures. So if we sort of painted a picture of why these risk factors, why these muscle injuries occur, these are the sort of well accepted risk factors for this type of musculoskeletal injury. So in conjunction with sort of talking to supervisors and looking at how we can actually stringently measure these, the TMG came up as a really innovative and potentially reliable measure for looking at what a single muscle is doing. Okay, so looking at its contractile properties, its function. We also decided to use DEXA as well to get a handle on the mass of the lean tissue in those regions that we are collecting. So clearly I can't get the lean tissue mass of the bicep femoris, but what I can do is get lean tissue mass of the thigh, and we can see if there's asymmetries in mass, has any relationship with asymmetries in function. And that's something that's not ever been done on football players before. So that was sort of a nice subsidiary study that's going to form quite an important part of my sort of thesis going forward. But fundamentally, we want to know about the physiology and the function of this muscle, and are we putting people back into play at the right time? Is there something that we can do to improve prognosis of injuries going forward? So I suppose that was the aim of this is the aim of my current study that's going on. So I've completed one season so far, and we're just about to start the second season in June, July this year for the 17-18 season. But we want to obtain 200 DEXA scans, 200 TMG measures on 200 players during these 2 seasons to actually get some nice quality and standardized reference ranges for a variation of muscle groups, individual muscles, according to the epidemiological data. So the methodology for this I've not sort of included in this presentation, but fundamentally I followed the suggested protocol for electrode placement. So this is before Hannah's stuff came out, because we'd already started this study. So 5 centimetres intra-electrode distance. But we have started to look at a standardised protocol for our probe placement. So we've tried to be a little bit very specific in the regions that we're testing. So I'm testing the rectus femoris bilaterally, the bicep femoris bilaterally, the adductor longus, the gluteus maximus, and then both the gastrocnemialis and lateralis. So I've selected 6 sites, and they're all lower limb because of the nature of the sport that we're involved within. And we've looked at the previous references and citations on probe placement, usually by EMG texts, sort of Delagi data texts in EMG studies or textbooks, and then we've tried to adapt that, looking at the angle of pronation of muscle and the origin and insertion of the muscle. So we've tried to devise some strategies, and that's actually due to be published in the next month or so, which I'll talk about in a second. So we've used that as our methodology, kept with the 10-second interstimulus time, and we're stimulating the muscle to the peak or the failure, as all the other studies have talked about, in increments of 10. So we've sort of followed most of the protocols that are widely accepted within the current text, but then we've also adapted our probe placement to try and be rigid, because I'm wanting some repeat measures from this. So I've got to be as standardised as I can. So we're taking the TMG, and we're also taking DEXA on these 200 players. We're going to analyse them as a TMG paper, so some reference ranges according to position. So these will be healthy players, and there'll be DEXA, and there'll be 200 DEXA scans as well. There might be actually slightly more than that, because we've got some other football players on other studies that we might pull in, and we can actually then come to some body composition reference ranges according to player position as well, which should help for injury identification and comparing baselines. Alongside this is also going to be a prospective, audit going on of load and injury. So each of the clubs that are involved in this will provide me with an account of each player's injury record across the season, in terms of what injuries they sustain, how long they're out for, everything to do with that, following the Fuller consensus from 2006, which is widely available and is sort of standardised across football. And then they will also be talking to me when they get injured, which I'll mention in a second. So, alongside this, I'm wanting the healthy baseline for the reference ranges, which we've just discussed there. But I'm also wanting to look at return to play. And I wasn't here this morning, I was changing nappies unfortunately, but I was following Twitter, saw Sergei's thing about muscle injury and how it changes, which is pretty timely, and I'm glad I saw that, so you've helped me out there. But what we expect is that when obviously a muscle gets injured, its performance will reduce, so its contraction time may well increase and its displacement may well decrease, because again, things are trying to heal and the healing properties will change that function. But what we don't know yet is what is the safe percentage, or is there a safe percentage for return to play using the TMG? So when that player's been out with a hamstring strain for 4 weeks and the club physiotherapist does all his strength testing, his flexibility testing, his range of movement, there's no pain, psychometric measures, anything else that they do, all their field-based work, is there, and we want to use TMG to look at function, is there a safe window that we've got? So if they're 5% slower than they were in their contraction, or if their displacement is slightly more or less, is that something that we can use? Or does it have to be exactly the same as what it was at healthy baseline? And we don't know these things yet, and I don't know these things, so please don't ask me them. But this is what I'm hoping to find out from the third aim. So I wanted to find out if it can be a stringent return to play protocol, or involved in the battery of testing that we will do with muscle injury. So all these things are going to be used in sport, particularly in football. You know, we might have them using isokinetic, we might have EMG, we might be looking at their ability to perform eccentric hamstring work, for example, or field-based testing. It might be a time-based compared to baseline. But we just want to know about this function as well, of the individual muscle that was injured. So the third aim, which is also going on at the same time, is to assess the change in muscle function immediately after. So let me show you the graphics. Okay. Immediately after, and then obviously at the return to play stage, we want to know what that third measure is, and is it safe, and what will happen when they go back in. So the idea is that I will be blinding clubs from that third measure, because I don't want to tell them your player isn't fit to go back into training or match play, because I don't know the answer yet. And I don't know if I can pin my academic background or my I suppose, clinical reasoning on that yet. But what I do know is that what I do want to know is, can we in the future? So I want to know if these players go back, we've tested them, and the club will just tell me, yeah, this player is fit to return to play. I'll be retesting the player on that structure, on that individual muscle and the opposite side as well. Let them go back in, and then we'll be following their injury record for the rest of that current season, or for 3 months after. So we want to know if they were the same, was there any correlation between injury or not? If they were slightly different, was there a correlation? And this is all coming from this previous injury being the highest risk factor for muscle injury. So it's telling us a picture here that you strain your muscle, regardless of your rehab, sometimes you are more likely to get injured, but in the future, could we use TMG to further inform us as to that, and how much can we pin our sort of hopes on that? So where am I today? So at this point in time, we're waiting for the pro placement journal, the article to be published, which we promised is going to be in the next month, 2 months, I think. It's yeah. Okay, so this will be in the inaugural edition of the ASMFA, which is really nice. It looks great in print, in the proofs anyway, so fingers crossed. And hopefully this will be heavily cited and used by clinicians in football. So it's tested on football players. It's from the 100 that I've tested so far, and hopefully it might just give people a nice reference point for where the probe should be placed in these individual structures. We're 100 DEXA scans in, and we're 100 TMG assessments in, and then I've managed to get 5 TMG repeat measures so far. So last season I only managed to get 5 due to sort of lecturing and other responsibilities I've got. So really the pressure's on this year to get that third aim nailed. I need to get another 15 to 20 repeat measures. So I've got a nice sample of 20 to 25. I can start coming to some conclusions. There'll be some correlations that can be assessed on whether these players are going back too soon, whether they're going back on time, what is their injury prognosis afterwards. So we're currently recruiting for pre-season again, and we've got 3 clubs confirmed, possibly a couple more in the pipeline to get this additional 100 of each. So that would be first team and under 23, so any player over the age of 18. And then we've got hopefully the repeat measures. So I suppose I am reliant upon the clubs buying into this, so that they ring me when there's an injury or contact me when there's an injury, and I can get out and test within 5 days, because that's the idea. I want to test before we get too many of the proliferative changes of healing. Okay, so I want to let the inflammatory response settle down. I want to let all the bleeding settle down in the first few hours, obviously, but I don't want to be getting through proliferation and start going into remodelling until we've got a measure. But then I want to get that last measure as well, so really important. So quite arduous to get the 3 measures, but be worth it if we can get that nice little correlation of the 3 measures. So the idea is to publish, obviously, the prospective audit of injuries for the 15-16 season, which we're just underway with, getting some final bits together on a conclusion there, and then obviously some reference ranges for these 200 TMG and possibly up to 400 DEXA if we pull the other information we've got. So it should be quite interesting from that perspective.